I herewith appoint you as an honorary orbital radiologist, not just a neuroradiologist. So this talk is about one technique that fixes everything. The one single slide answer for this is there's none that exists. But I'm just going to show you a simple slide variation to what I do for lower lid laxities. So we all know about entropion. There has to be literally an inward rotation of the lid margin, not just the anterior lamella alone. Because if the anterior lamella alone turned in, then it's called an epiblepharon. And not infrequently, the lid margin is perfectly fine, but the lashes are pointing in different directions. That's where if you have an additional row, it's a distichiasis or tristichiasis, or otherwise it's a normal origin, but pointing against is trichiasis. And sometimes we clinicians abuse these terminologies like Rich was talking about and the neuroradiologist, the orbital radiologist was pointing out earlier on as well. So by default, the most common type of an entropion is an involutional or politically corrected age-related entropion itself. And if you look at the pathogenesis, whether it's an entropion or ectropion involutional, by default, the most common predisposing factor is significant lower lid laxity. In the past, it used to be thought it was the tarsus which is lax. It's not the tarsus lax, but it actually is the lateral canthal tendon. And then on top of which, you have a lower lid retractor dehiscence, along with a lot of other factors itself, which is what causes lid instability, and depending on which way the wind blows, it becomes an entropion or ectropion as such. But if you're trying to address most of these malpositions, if you're even able to address lid laxity well, even without manipulation of the lid retractors, a lot of times you can get very good correction, regardless whether it's an entropion or ectropion. So you want to assess the lower lid laxity. I think my timer is not on. That means that's great. I get extra time itself. So, but you want to address both the medial and lateral canthal tendon laxity. If you don't have too severe a medial canthal tendon laxity, even a mild to moderate laxity, you don't have to address it. Go ahead, fix the lateral canthal area and the lateral canthal tendon laxity. Most of your problems are resolved. So coming to management itself, there are various things you can do as a temporizing procedure or as a definitive procedure. Some people believe QuickArts works very well. In my hands, it only works about 50–60% of the times because it does not address the issue of laxity itself. So keep that in mind. The workhorse procedure for lower lid laxity has always been a lateral tarsal strip. That was described by Richard Anderson and Gordy, and I think that's considered the gold standard of lower lid laxity procedure itself. And you all are very familiar about it, and where you do a canthotomy and inferior canthalysis, the chop off piece of the lateral canthal tendon, and reattach to the lateral canthal. And that's what I learned with as a fellow itself. But the problem with the lateral tarsal strip is, number one, it causes lateral canthal angle malformations. If you do not reconstruct the sharpness or acute angle itself, you can get rounding of the lateral canthal axis. If you put a suture there, not infrequently you get a suture granuloma, and every once in a while you get cheese wiring. But the advantage is it works very well for severe lower lid laxity. So this was described elsewhere, and I think Rich Allen has got a beautiful video of a canthotomy sparing lateral canthoplasty, and if we can play the video, here we go. This is under local anesthesia. We just make a small stab incision in the superomedial eyelid. We make a small stab incision along the gray line of the lower lid. There's no canthotomy here, no canthalysis here. And what you're doing is we're using a 4-0 max on here, and what you note in that particular part, there's a knot on it. Unlike the regular suture you just pass along the lower lid margin, that knot engages the sub-lid margin tissues and gives you a good anchor, which in turn you end up attaching to the supratemporal lateral canthal tendon. So if you are a beginning surgeon, if you have a patient who's very sick, who's not going to be having a lot of cooperation on the table, they're on blood thinners, this is a simple procedure that I use in a vast majority of my lower lid canthal malpositions. And I now throw it in as a routine part of the lower lid blepharoplasties when I do it for 50-year-old and plus. I actually do it as a staged procedure whereby when you're doing a brow lift in a patient who's got diverticulosis, upper lid ptosis, and lower lid malpositions, at the same time I would do a tighten the lower eyelid. If you want, you can throw in the simple subciliary incision. Can you play that video one more time if you don't mind? So those of you who didn't catch it, if you don't mind. Just click on the video one more time. And yeah, so basically a stab incision, go down to the supratemporal rim. You don't need a big incision, stab incision of the gray line, okay? That's a 4-0 maxon suture. This is one of the few situations I use a 4-0 suture. engage the supratemporal orbital rim. So you're literally hitching it up to the periosteum along the supracanthal angle. And you can see the big knot there, which is going to engage the lower lid and the lateral canthal tendon. And then you get that anchoring. Okay? So the advantage of this procedure is simple, it's fairly effective, except in cases who have very profound laxity of the lower eyelid, where invariably, yes, you have to kind of chop off part of the lateral canthal and the lower lid itself. It's very versatile. Like I said, you can use it along with your blepharoplasties, entropions, ectropions, and other conditions as well. Even if you're doing a lower lid reconstruction in a 50-plus-year-old gentleman where you're going to have a lower lid retraction, you can use it. It addresses several pathogenic factors. You can vary the nature of the procedure through the upper lid stab incision. You can go down to the lateral canthal tendon, even release the lateral canthal tendon if you want. You can plicate the lateral canthal tendon through the upper lid creases itself, and works for even the anophthalmic socket conditions as well. So in summary, he wanted a simple procedure for lower lid entropion or lower lid malpositions. You can go ahead, try it out for your patients. Thank you very much.